Thank you very much. And basically, we have heard two competing approaches for a patient like ours. My task here is to talk about a third approach, and that is whether VAD or transplantation can be considered in this patient directly. So the question is, can such an approach be the standard of care? You've heard multiple VAD talks yesterday, and some of this will be repetitive, so I hope that we can consolidate some of the information that you have heard so far. But my task is also to tailor that information to our specific case that was presented earlier by Dr. Walid. So we know that functional severe MR is a result of LV dysfunction. Is basically, the question really is that, is it an innocent bystander or a predictor of adverse outcomes? Because it's a marker of a poor LV function as opposed to primary mitral regurgitation. And to answer this question, there have been a couple of studies that have looked at this, but the most influential paper came out of Italy in collaboration with the Mayo Clinic back in 2011. Investigators here looked at a sizable number of patients and examined them retrospectively with advanced both ischemic and non-ischemic dilated cardiomyopathy, and found that 24% of these patients had severe functional MR, and they stratified them according to the degree of MR. And what they found on multivariate analysis and logistic regression is that severe MR is an independent predictor of worse outcomes, higher NYHA functional class, lower mean ejection fraction, and worse diastolic filling parameters. And that also translated into worse hospital-free survival, with values approaching 80% by 6 months and 70% by 1 year in the cohort with severe functional MR. Survival in general was also worse in this cohort. So a patient who has severe functional MR was found to be an independent predictor of higher mortality. Survival at 1 year was dipping below 80%, and by 2 years it was dipping below 70%. So one can make an argument that since severe functional MR is an independent predictor of worse outcomes, it should be a legitimate target for treatment. We've heard two excellent talks where speakers talked about surgical intervention and percutaneous approaches. The issue is, from my standpoint, really, the bottom line is that there's no conclusive evidence that surgical intervention changes mortality or provides any survival advantage. A lot of the issues may have to do with methodological issues. Studies are mostly non-randomized observational. The degree of MR recurrence in the repair cohort is high, and there are issues with the way MR was quantitated. A lot of these studies relied on color Doppler as opposed to quantitative techniques. As far as percutaneous approaches are concerned, there could be a potential role in the future. This is certainly a very appealing option because the initial upfront risk of an intervention is very low. But so far, until the completion of randomized clinical trials, ReShape, HIF, COAP trials, we really don't know if MitraClip is going to change mortality. Definitely translates into better NYHA functional class and reverse remodeling, but survival advantage is yet to be demonstrated. So how do we make decisions as far as interventions are concerned? I'm just putting this out because we do this all the time, but this is a point of reference for me in this talk. An intervention is justified when it will provide better outcomes compared to no intervention in terms of ideally better survival. And if that is not achievable, and we see that in patients who are less and less sick, that an intervention may not be able to provide better survival, it should at least provide a better quality of life. The quality of life is a ill-defined, undisciplined area in research. We have lack of standardization, different techniques to measure quality of life, and it makes it very difficult to compare different data sets. But for a patient who is having recurrent hospitalization, a patient who's having adverse events related to an intervention with GI bleedings or, for example, infections, I really don't need a sophisticated metric that is ill-defined to tell me that this patient has poor quality of life. So the interventions that we can consider in our patient is to, first of all, directly list them for transplantation, consider VAD therapy as bridge to transplant or VAD therapy as a destination. And this is just to highlight why transplantation is still considered in 2015 the gold standard of treatment in patients with advanced heart failure, because the expected survival is 85% at 1 year at least, and 79 to 80% by 3 years out. There is some regional variability, with the North American cohort performing better than the international averages, achieving consistently above 90% 1 year survival. And that difference stands out up until 3 years, where the North American cohort is achieving more than 80% survival at 3 years, as opposed to the international numbers, which stand somewhere between 78 and 80%. We have to take into consideration the local scene, as Dr. Fahad talked about this yesterday, and this is sort of a representation of what's been going on in Saudi Arabia as far as heart transplant is concerned. The blue bars here represent the total number of transplants performed at all centers. The red bars represent the transplants that were performed at a single center in the capital city of Riyadh. And this tells us a bit of a complex story, because when this started off early, back in 1987, there were a couple of centers, including 2 here in Jeddah, that were performing transplants. But ultimately, they ran into logistical issues, and the burden of doing transplants ultimately fell on King Faisal Hospital in Riyadh. And for the most part of year 2000 and onwards, that's been the only center. And their numbers average comparable to an average-sized transplant center in North America, but they have peaked out probably, and now they have been supplanted by another center in Riyadh. So hopefully these numbers will improve. But the total number of transplants in Saudi Arabia still stands at around 242 since 1987. To put that into context, with another country, not comparable in size, but of comparable population and somewhat comparable economy, there's a huge disparity in number of transplants. This is not only a Saudi problem. You've seen the slides multiple times. This is a global issue where transplantation is really a North American or Western phenomenon, so to speak, driven mostly by Europe and North America. But even in those regions, the number of transplants have plateaued somewhat in the last 2 decades. One might worry about the low volume center and experience and how that translates as far as survivals are concerned. But the survival data that is coming out from King Faisal Hospital in Riyadh is reassuring. Their numbers are comparable to the international numbers reported in ISHLT. So beyond survival, gains in functional status are an important metric of quality of life, and patients post-transplantation do exceptionally well. 5 years out, 90% of these patients will have functional status of 80% or more, according to the Karnofsky scale, which is used in palliative care and oncology literature. And this is also translating into better freedom from rehospitalization. So transplantation, post-transplant patients can expect to stay out of hospital up until 5 years. Freedom from rehospitalization is around 70%. And if hospitalizations do happen, they're usually not due to serious causes such as infection or rejection. We need to individualize the risk to a particular person. So the underlying cause of cardiomyopathy dictates how the long-term outlook is going to be post-transplant. This patient like ours who has non-ischemic cardiomyopathies is expected to do better. Other individual factors that are taken into account are recipient age, pre-transplant creatinine, and a variety of other metrics. So a patient who is older obviously is going to do worse. A patient who has elevated pre-transplant creatinine is going to do worse, and the expected mortality is going to be unacceptably high. And these patients do succumb to problems. The leading cause of death is graft failure, followed by infections and multi-organ failure. So how can we individualize this data for our patient? Initially, we start off by assessing their functional class. So if our patient has NYHA functional class 3 or 4 symptoms, despite optimal medical therapy, despite things that are proven to improve survival, neurohormonal blockade, CRT, and revascularization, for example, and potentially mitral valve intervention, then those options should be exhausted first. If we flag a patient and is classified into someone who could benefit from transplant, then we apply a risk score to estimate and individualize how will this person do according to their natural history. So a Seattle heart failure model can be used, the heart failure survival score can be used, but all these risk scores, they have confidence intervals. And a patient who has severe functional MR, the risk scores may not entirely capture their actual survival. Once a patient seems to have a natural history that is going to be worse than an intervention such as mechanical circulatory support or transplantation, it is then time to really consider them for transplantation. And before you do that, you have to do objective assessment with peak oxygen consumption. One needs to be aware of all the absolute contraindications. Systemic illnesses that limit survival to less than 2 years are all absolute contraindication. And the key hemodynamic parameter is pulmonary vascular resistance. It needs to be less than 3, and if it's above that, reversibility needs to be demonstrated. And then there are a host of relative contraindications. And as Dr. Fahad talked about, a key one, aside from the comorbidities, is a psychosocial aspect, which is difficult to predict and measure. If a patient meets these criteria, then they can be listed for transplant, but they're going to be competing with more sick patients, so they will end up on a wait list. And these are the numbers from King Faisal Riyadh, where we can see that the average number of days on the waiting list have been increasing. There's a spike since 2012, likely a reflection of higher referral rate and the fact that they cannot really meet the demands. So transplant could be a viable option if the patient meets the criteria. It is a scarce resource and is plagued with wait times. So you need to have a bailout strategy, and that bailout strategy is mechanical support. We have seen this slide multiple times. Initially, when mechanical support was investigated, they were using bulky 1.2 kilograms pulsatile devices, the HeartMate XVE or HeartMate 1, and it was compared to patients who were transplant ineligible. These were very sick patients. 70% of them were on inotropes, and in the medical arm, their survival at 1 year was dismal at 25%. The device managed to double that survival, but the advantage did not last beyond 2 years because of device-related complications. And as they moved on from a pulsatile design to axial flow design and reduced the size from 1.2 kilograms to 360 grams with HeartMate 2, the durability of the device resulted in better survival at 2 years. So there was a doubling of survival. So all of these studies of mechanical support, if we look at studies of mitral valve intervention, the clinical study of mitral valve intervention will never include patients who are this sick. So clearly there's an advantage for mechanical support in the very ill patients over mitral valve intervention. And we don't really have any direct comparative data of current generation mechanical circulatory support versus mitral valve intervention to provide guidance in the less sick patients. Whenever you have randomized studies that prove the efficacy of an intervention, it becomes increasingly difficult to do ongoing randomized trials because the comparator is always better, and it's difficult to demonstrate survival advantages in setting of small randomized trials. So you need to have registries, and the INTRAMAX registry, the vision was basically to track the outcomes of patients who undergo VAD implants in North America. This was established in 2006, and it was a successful collaboration between the industry and regulatory authorities in North America. We've seen this slide where there's been an uptake in the number of implants, and now they're exceeding 2,000 implants per year consistently since 2012. And their survival is variable according to the device and strategy that is used, but continuous flow LVADs are consistently outperforming other strategies. So this is the recent data where expected 1-year outcome is 81% and expected 2-year outcome is 70%. These are certainly numbers that are much better than the HeartMate 2 pivotal trial data, but they still include a hodgepodge of patients, those who are younger, older, bridge to transplant, transplant ineligible. Everyone is lumped into the data. The INTRAMAX level is a very important contribution of the INTRAMAX registry because it helps us select our patients better and hopefully track their outcomes. NYHA class 4 is a very vague term that needed to be refined further. And INTRAMAX levels 1 to 6 are all NYHA class 4. 1 to 3 are those who are inotrope dependents. 4 and above are ambulatory patients. And if we look at the types of implants that have been done over between 2008 and 2013, according to the INTRAMAX level, the vast majority of these patients are INTRAMAX levels 1, 2, and 3. You can notice that the numbers of patients with INTRAMAX 1 are steady, and in fact they are now declining because there is increasing recognition that these patients are futile, so they're not going to benefit much from the intervention. And there's an increase in the number of INTRAMAX 3 and less sick patients. Our patient who has NYHA functional class 3 symptom would probably fall into this category. It would probably going to be an INTRAMAX 7 patient. So just as we talked about individual risk variables to predict post-cardiac transplant mortality, there have been attempts to identify variables that can predict post-VAD outcomes, and the key ones are age, which are associated with the highest hazard ratio, INTRAMAX level 1 and 2, renal dysfunction, dialysis status, as well as right-sided dysfunction. So lower age translates into better outcomes. So our patient is 30 years of age, so they can expect to have better 1-year and 2-year outcomes. Intermax level of implantation is also a predictor. So if a patient is Intermax 1, as we know, they're going to have worse outcomes compared to the other Intermax levels. 3 and 7 pretty much have overlapping curves. And within Intermax 3 and 7, if you can identify a cohort with the least risk, those who have a low HeartMate 2 risk profile, those who had not had prior cardiac surgery, for example, their expected survival at 1 year is approaching 90%, and at 2 years, 80%. And this is really comparable to post-transplant outcomes, at least in the short term. And as the device technology advances, we are seeing better outcomes as well. So centrifugal devices such as the HVAD versus HeartMate 2, we can see that there are improvements in survival which are meaningful for patients who are implanted with these devices as a destination therapy. So our patient, however, has had recurrent hospitalizations. So the Intermax, when it was initially envisioned, it has these 7 categories, but then they added qualifiers. And one of the qualifiers is a frequent flyer modifier. So this patient, any patient who has at least 2 emergency visits or admissions in the past 3 months or 3 in the past 6 months, requiring ER visits for IV diuretics, vasodilators, or inotropes, they need to have this added as a qualifier. So how does that translate? What about Intermax levels 4 and above? What is their natural history? To answer that question, the people who come up with the Intermax registry wanted to establish a medical arm as well. These would be patients who, out of their own preference, did not elect to have VAD implants, or initially it was not indicated. And this arm was created to assess whether Intermax profiles 4 and above can predict their outcomes. And what we are seeing, that freedom from VAD, transplant, or death varies according to the Intermax level. So patients who are Intermax 4 have sort of, poor prognosis compared to those who are Intermax 5, compared to those who are Intermax 6 and 7. This is, again, pilot data because they're planning on including up to 300 patients in this registry, and this is a report that is based on inclusion of about half of that number. The expected survival advantage with VAD in this population at 1 year is going to be 85%. So not a huge advantage, but there is a potential advantage that is seen. However, we do need to take into account the adverse events that are related to an intervention because they're going to impact quality of life. And these patients are susceptible to infections, they are susceptible to pump thrombosis. We have talked about this extensively. That being said, what is interesting enough that not only do they have fairly high readmission rates, but that readmission rate is not going to vary according to their baseline Intermax. So Intermax is going to dictate their mortality, but it is not going to impact their readmission rates. There are quality of life improvements despite all of the adverse effects. Pre-implant versus post-implant patients do benefit in terms of the European Quality of Life score. Some of the patients will suffer from severe problems ongoing, whether it's in usual activities or self-care, but what you're seeing is an ongoing trend that the degree of severe problems is getting less and less in the most recent implants compared to older implants. So this is sort of a philosophical discussion. When we have a medical intervention that is providing basically poor outcomes, and then we have another intervention, such as mechanical circulatory support, that has better survival, we need to quantify how much of an advantage we are getting. But that is not only enough. We do need to take into account the impact of adverse events. So hypothetically speaking, if adverse events combined with survival with an intervention such as mechanical circulatory support ends up with worse outcomes compared to no intervention, then in that case, that intervention should probably not be considered. But if you are able to show that survival is better with an intervention and incorporating their adverse events, their outcomes are going to be better than the medical therapy alone, then that should favor the intervention. And there are a couple of ongoing studies. Dr. Estep talked about the roadmap trial, which shows that there are already indicators that patients with mechanical circulatory support and lower Intermax profile do derive benefit. Although they have more adverse events compared to the medical therapy arm, their quality of life is better. So I think we are heading into that direction. In our case, VAD is bridge to transplant. If you have that option available, if you have the option of transplant, if you have a robust VAD program, it's supposed to offer the best survival outcome because there's no mortality advantage shown with MitraClip or mitral valve surgery. The MitraClip has the biggest advantage of being less invasive. So if it improves quality of life, that is great. But in terms of survival advantage, VAD as bridge to transplant probably has its own merits. VAD as destination therapy will likely improve survival in our patient, but quality of life may become comparable to no intervention in the long term. And a final note, decision-making in less sick patients will be increasingly driven by considerations beyond survival. Quality of life incorporating adverse effect profile will affect this calculus. So thank you very much.
Thank you so much, Dr. Ammar.